Good evening. I'm Dr. Alan Keller, and on behalf of NYU School of Medicine and the Master Scholars Program in Humanistic Medicine, welcome to this very special event this evening with Dr. Oliver Sacks and our own Danielle Ofri. Dr. Sacks, actually, this is his welcome. And I think it's a real tribute to our School of Medicine that we have someone like Dr. Sacks on our faculty, and that we have a program such as ours, the Master Scholars Program, at our School of Medicine, which the essence of what our program is about, now more than 10 years old, is about promoting humanism, compassion, and professionalism in our medical students, in our future doctors. I'm always thinking about what do I want in the person that's going to be taking care of me. And it's a tribute to our School of Medicine that we have Dr. Sacks, that we have this program, a tribute to our Dean, Bob Grossman, our new Chair of Medicine and Vice Dean for Academics, Dr. Steve Abramson, and to Lynn Buckvar, the Dean of Students, and a special thanks to Katie Grogan, who frankly is the organizational glue that binds our program. And in addition to events such as this, we have the opportunity of hosting other colloquia, of hosting seminars on a variety of topics, and opportunities for students to pursue endeavors outside of their traditional curriculum. And on that note, it's that we, with great joy, host this evening's event. Let me just say a few words about our discussants. Dr. Danielle Ofri, who will be moderating, participating in the conversation with Dr. Sacks, is a dear colleague and friend of mine since we both graduated from medical school, known each other for over 20 years. Danielle is a primary care physician. She, like Oliver Sacks, is also, at her essence, a great humanist and humanitarian. She's also an accomplished author. Her most recent book, which I'm not sure if this one is available yet, What Doctors Feel, talks about the inner emotions of the practice of medicine. Oliver Sacks has been referred to as the poet laureate of medicine, and for some of us, actually, Danielle is a local poet laureate who captured, frankly, what we were going through here at our School of Medicine and Medical Center during our recent challenges in the storm. So we're really lucky to have Danielle here. And we are extremely fortunate to have, as I alluded to before, the poet laureate of medicine, Dr. Oliver Sacks. Dr. Sacks has a long and accomplished career as, first and foremost, a physician, a caring physician who actually still follows patients, I understand, that he's been caring for decades. We know him in the public as a gifted writer, author, artist, and really one of the great thinkers of our time. Dr. Sacks literally and figuratively helps us not only get inside the minds, but I believe also inside the hearts of individuals who step up to the challenges of a variety of neurologic conditions. His most recent book, Hallucinations, explores the world of individuals who experience hallucinations, and actually I believe will be available for sale afterwards as well. And by your being here tonight, in addition to hearing the wisdom of Dr. Sacks, you also have the opportunity to get this book for 20% off. Plus, actually, Dr. Sacks will be available to sign copies of the book. So we at NYU are thrilled to have Dr. Sacks here. We also owe a debt to my friend and colleague, Dr. Orrin Davinsky, who runs the Comprehensive Epilepsy Center, for helping to bring Dr. Sacks here. But without further ado, let me welcome to the chairs Dr. Oliver Sacks and Dr. Danielle Ofri.
Good evening, and thank you all for coming. Thank you, Oliver, for joining us for this interesting evening. Thanks to all of you who came out, and those of you who are at home watching, we really appreciate that. The audience was a bit too large to take questions in general, but many audience members submitted questions online, and we'll try to include as many as we can.
Before any questions, I want to say that I know what a rough time it's been at NYU since Sandy. And I think there's been amazing resilience and recovery, and that I'm very happy to be part of the NYU family now, and that I'm blind in my right eye and cannot see anything to the right of my nose. So I can't see you people, but I know you're there.
But I can see you. Dr. Sacks, your writing has been an inspiration for many doctors, for many writers, and many readers. But many of us doctors have wondered, are your patients just much more interesting than the patients that we see? Or do you simply pay closer attention to their stories?
If it's not immodest, I think the latter. I'm in an often with neurological patients, attention may be the only thing you can provide. But although I've written about some people with exotic problems, I also do general neurology clinics and see people with everything.
And how do your patients react when you tell them you'd like to write about them?
Well, this is not something which would come up early, probably only after I've known a patient for some years. And they may have guessed what was in the back of my mind even before I have divined it. Well, it's discussed, and I'm open, and at every stage I will sort of be partners with them. So they will certainly see the final manuscript, and if they don't like it, I will stop it at that point, or they will correct it, or they will add to it. And I did wonder about this very much. Well, I've wondered about it for the last 50 years, but back in 1970, the sister of one of my patients held up the New York Daily News and said, is this your professional confidence? I had written a medical letter to the Lancet in England, but they had sent it to the media, and so it got out. I mean, no one could have recognized the patient except her sister. When I was writing Awakenings, I thought my patients were in New York. Perhaps if I only published the book in London, it'd be okay. But one of the patients sort of got wind of this very quickly and ordered a book from London. And since then, I've been open.
And have you ever found that the act of writing about the patient has brought to light another medical point of view, a change in the diagnosis, either from your own writing or the patient's reading of the manuscript?
Yes, I think this often happens. I don't quite know what I'm going to write in advance. Indeed, I don't know the end of any sentence in advance. And the act of writing is full of surprises for me and makes me think of things, and so too may patients' reactions.
Do you ever worry about the increasing HIPAA regulations that have changed the issues of patient confidentiality recently as opposed to 20 or 30 years ago?
What do you have in mind?
There's the new regulations. We have to take these courses online every year to comply with them, that the patients have control over their story and that we can't divulge anything that would be confidential doctor-patient interaction.
Well, I was going to say I don't take that literally. No, and I think the question of what is confidential is a matter of discussion, and it's a matter of tact. And I think tact and delicacy and sensibility are much better guides than any regulations.
Do you ever worry about the voyeuristic aspect of writing about a patient's unusual symptoms or appearance? I mean, are we doctor writers exploiting our patients for their dramatic story?
I do worry about that. And for a long while, I made all sorts of Freudian errors, so I would misread the word portrayal as betrayal, and publish as punish, and a few. I think that if one has respect for the patient and their situation, and that shows, that will make the piece emotionally and ethically okay. Although then there is another level of worry if what one writes is going to be turned into a play or an opera. This happened with the man who mistook his wife for a hat. I said to the librettist, you have to visit Mrs. P and be open with her. In fact, the two of them became very good friends, and she is a much more interesting person in the opera than in the case history. But I watched her when the opera was being performed, sort of very nervously from an aisle, and I wondered what she was thinking. But she came up to us and she said, you have done honor to my husband. And so in general, I hope I can do honor to the patients. But it's a tricky business, and I have written at least 20 case histories for everyone I've tried to publish. I will often write a case history because I love case history, I love writing, and as I said, it clears my mind. Sometimes I don't know what I think or feel until I start writing.
I wonder if you might comment on another form of writing, the traditional letter. The epistolary tradition in writing is a long one, and for me it's personally meaningful as we first communicated via letters. And I know that many, many people write letters to you, the kind on actual paper with pen.
Well, yes, especially now with email, letters are in, I don't know, are several thousand a year. Some get filtered, but many fascinate me very much or arouse my feelings, and I will write back and perhaps inquire more, or if the person lives near New York, I'll suggest that they come and see me. After my book Musicophilia came out, I got innumerable letters of the form, what you say is very interesting, but I have something which you haven't mentioned in the book. And often I would write back and say, yes, you're right, tell me more, and can I quote you? And in fact, the paperback was 40 pages longer than the hardback, that 40 pages consisting entirely of patient letters. I like writing letters myself. My first medical publications were letters to the editor. I partly think of a book as a sort of letter to everybody, or a letter to anybody who's interested.
I want to talk a little bit about your new book, Hallucinations. And I wanted to open with a quote. The theater of the mind is created by the machinery of the brain. It's a quote that I find very incisive, especially as it was spoken about in the mid-1700s by Charles Binet, and you use that quote in your book to open up an exploration of the theater of the mind. And perhaps you can tell us how this book came to be.
Well, I've been interested by hallucinations as a mode of experience and a mode of consciousness, different from imagination, different from dream, different from perception, different from anything else. And the way in which it can be full of drama and color, but also created by parts of the brain over which one has no control. Most but not all of my work is with old people in nursing homes and with the Little Sisters of the Poor, and it became apparent to me by 1980 or so that a good number of people who have poor hearing or are deaf have auditory and especially musical hallucinations, and the blind or half-blind have visual hallucinations. I start the book with a story, with a case history. I love narrative, and my life, and I guess your life, and our lives as physicians and as patients consist of exchanging narratives one way and another and trying to extract some sense. But I was asked to see an old lady in the Bronx who had started hallucinating, and the staff didn't know what the matter was. They wondered if she'd gone crazy, if she was demented, if she'd had a stroke, if some medication was upsetting her. And she herself had all of these thoughts, and I asked her what she was seeing. The nurses had observed that she was hallucinating because although she was blind, she was looking around. One responds to hallucinations as to perceptions. You cock your ear, you sniff, you look around. She said that she was seeing people in exotic dress, ranks of them marching in one direction. She was seeing animals. None of the things she saw seemed to have any relation to her feelings or her thinking. She couldn't influence them, and they didn't seem to be aware of her. And I said, is this like a dream? And she said, no, it's like a movie, or fragments of movie, like bits of silent movie. And sometimes she said that it can be a rather boring movie. She says, all these people in Eastern dress. So the book starts with her, but every sort of hallucination comes in, and every sort of way in which people respond to hallucinations. Now, Charles Bonnet was a naturalist, and in the middle of the 18th century, his grandfather, who was almost blind, but intellectually very intact and working as a magistrate, started to have hallucinations. And the grandson wrote briefly about this. But the grandfather rather enjoyed his hallucinations, and he would have a hallucinatory matinee in the afternoon when he would go to a room where he could be undisturbed and just enjoy the theater of his mind somehow being produced by the machinery of his brain. Charles Bonnet himself made a guess, and really people had no idea about the brain in the 18th century, but Charles Bonnet thought that there must be parts of the brain devoted to different senses, and that the visual part of his grandfather's brain was somehow being stimulated and behaving autonomously on its own. But it's a beautiful description, that.
Well, Charles Binet also asked his grandfather to keep a journal of his hallucinations, which I thought was fascinating, the early gathering of data in the written form.
Yeah, he asked his grandfather to dictate, and the grandfather dictated 18 pages, which were then lost, actually for 150 years, and then found at the beginning of the 20th century. This was a year or so after the interpretation of dreams was published, and was a sort of feeding frenzy of psychiatrists who thought that hallucinations might be a royal road to the unconscious, but they found that this sort of hallucination anyhow was not. And on the whole, the hallucinations aroused no particular associations or emotions.
Well, how do we know that a hallucination is not real? If all that we see and hear is perception, do we need society to tell us what is real and what is not?
Well, we may. If we agree about something in front of us, if there's consensual validation, well, either it is there and we're both seeing it, or perhaps we're sharing a delusion. But one of these startling and frightening things when people hallucinate, they may assume that they are seeing children in the playground or whatever, and make a remark to someone else who says, "What are you talking about? There's no one there." And the answer, "There's no one there, I don't see it, none of us see what you're seeing," is very startling and very frightening and also very intriguing. But the shock of hallucination for the first time is very great.
Have you had experience with hallucination?
Oh, lots. I get classical migraine, which I've had since childhood, and one can have various hallucinations with those, although they're of a very simple sort, usually geometrical patterns. Although a colleague of mine, who is in the audience, I think, tonight, and a great expert on migraine, describes a patient, one of his patients, who in every migraine would see a man emerge from a manhole wearing I think a hat with a flag on it. He knew that it was a hallucination, but it occurred nonetheless. I've occasionally had olfactory hallucinations with a migraine. It starts with the smell of hot buttered toast, which I love, and which I take to be real. Although once when this occurred, when I was in the car on the Cross Bronx Expressway, I knew it couldn't be real, and it was then followed by zigzags. I took, and rightly or wrongly I've described this in the book, I took all sorts of drugs in the 1960s and had all sorts of hallucinations, some ecstatic, some terrifying, and some very commonplace, except they were hallucinations, and that with one of them I'd taken a lot of, well, I don't know whether I'd taken a lot of Artane tablets. Artane is a synthetic belladonna drug, which used to be given for Parkinson's. The belladonna drugs produced delirium. And I didn't know what to expect. People said, just take 20 of them, you'll still be in partial control. And I did so, and I really didn't notice anything, except I got a very dry mouth and had difficulty. My pupils became enlarged. And I thought, big deal, nothing's happening. And then I heard a car coming up the drive, and my friends, Jim and Kathy, who often visited on Sunday morning, I said, "Come on in, the door's open," and we chatted. I was in the kitchen, there were little swing doors. I said, "How do you like your ham and eggs?" And 5 minutes later, I went out with a tray with ham and eggs for the three of us, and there was no one there. And I almost dropped the tray, and it's very startling to realize that I'd been hallucinating and had no usually with visual hallucinations, you sooner or later realize they are hallucinations. I think it's more difficult with auditory ones. And of course, people with schizophrenia get mostly auditory hallucinations, although I haven't. These need a separate book. I haven't written about much. Now, like Charles Bonnet's grandfather, and for that matter, Charles Bonnet himself when he aged, I am half blind. I have no sight in this eye and not terribly good sight in the other, and I have some little hallucinations myself, but they are mostly just geometrical, and I both hope and fear that they go further.
Well, I'm wondering, you talked about in the mind's eye, Lillian, the patient with posterior cortical atrophy, who was a concert pianist, and as she lost visual input and was unable to read the scores visually, her mental agility with music improved. She was able to sight read, a so-called sight read after hearing a piece just once. She was able to rearrange scores in her head. Has that happened to you?
Well, I'm somewhat deaf as well as somewhat blind. I think my sense of smell has improved, but also it has taught me to decipher my perceptions rather more carefully. But with Lillian and with so many of the patients, I think it's amazing to see the sort of adaptations which occur, and quite spontaneously sometimes. Lillian's auditory imagery and her musical imagery was hugely amplified. With another patient I describe, a Canadian, a novelist who got alexia and became unable to read, and thought this was the end of him as a writer, and that life would be very difficult because, of course, the world is full of writing. But after a while, he found that reading was coming back to him, and he thought, he went to his neurologist and said, I seem to be improving. He was tested carefully and told that there wasn't the faintest sign of improvement. But what was happening unconsciously was that he was copying what his eye was seeing with his tongue on the back of his teeth. People with alexia of this sort can write, though they can't read, and basically he was reading by writing unconsciously with his tongue. And I wouldn't have thought such a thing possible. In general, reality exceeds what one could imagine.
Although when I read about Lillian and her improved musical ability, I have to say, a little bit envious of her abilities. I mean, those of us who sweat over our scales and etudes might actually want some of that enhanced ability. I mean, could there be a benefit, in quotes, to a neurologic illness?
Autistic people often have amazing abilities of one and another, but sometimes abilities develop following a head injury or following a stroke. And certainly when I see patients, I'm as much at pains to try and delineate what may be spared and what may be worked with, as much as what can be lost.
Does that change the way we look at illness? I mean, traditionally we see illness as a set of symptoms or problems, and in fact we call them problems, but you look at it a little bit differently.
Well, alongside the set of problems, I think of the person as being in a different sort of situation and needing to call on other qualities in themselves and their environment. For example, with Lillian, whom you mentioned, Lillian was not only unable to read music, but she then became unable to recognize anything visually. And I saw her here at NYU. I tested her with various drawings and objects, and she was hopeless. And I thought, my God, how does this woman survive? How does she function? How does she manage get through the city? How does she give concerts? How does she teach? I felt I had to see her in her own environment and make a house call to see how she managed. And one of the remarkable things was that everything in her house and all the books and other things were organized in terms of color and shape and congruence of one sort and another. And she had mapped her house, and she had also mapped her neighborhood and her local supermarket. And so she was calling on every sort of ability and compensation there was. But I think everybody can make compensations of some sort. But this is not to say that an illness is fun.
Well, you've had a few experiences of being a patient. How has that changed you as a person and as a physician or a writer?
Well, I was probably an awful patient. In fact, this was said to me in a rather acute situation when I was, I had to have a rotator cuff repaired. And I said, could I watch it on a TV monitor? And they said, fine, but don't talk. I think I talked a great deal before we went into the OR. I was, when I was a patient with a nerve muscle injury in a leg, and a feeling that the leg wasn't my own, as was paralyzed and very strange, I found the inability to communicate my feelings to the surgeon almost worse than what was happening with the leg. I think he was a very good surgeon and a sort of good carpenter. But one needed someone to listen and someone to be empathic.
Do you think that he wasn't able to hear, or that we lack the vocabulary in English to convey the gradations of pain?
I think probably both, and he was also impatient. I'm sort of long-winded, as you hear. And he said, Sachs, you're unique. I've never heard anything like this, and flounced off. Now, subsequently, I spoke to several of his other patients, and I found that some of them had had syndromes of alienations, so-called, very similar to my own, and had also been frightened by the inability one way and another to articulate, certainly to communicate, and sometimes to articulate what was happening. So I think as a physician and as a writer, one needs to give vocabulary and concepts to people.
I'm curious about the sensation of your leg that we couldn't really put into words. And it makes me think a little bit of phantom limb pain. Is that at all a hallucination?
Well, a phantom limb is a hallucination insofar as you feel something which is not visible and not there. On the other hand, it's not out there. It's part of your body, and it is, in a sense, a continuation or persistence of the normal body image and the normal feeling of a leg, despite the fact that there's no longer a leg. The experience I had is sometimes called the negative phantom, when you feel there isn't a leg, though there is a leg. And this can happen if there's damage to peripheral nerves or spinal damage or cerebral damage, so that you're not getting enough information from a limb, nor can you send commands to it. And then it's sort of out of the circuit. Incidentally, and you can all try this for yourselves, if you have a spinal anesthetic, I don't mean one of these silly little epidurals, but a real hefty spinal, you will not only lose sensation from, say, the umbilicus down, but you will have this uncanny feeling of a pair of legs and hips which are not yours, although somehow continuous with you. And I do, in fact, in an afterword to my book A Leg to Stand On, suggest that it be read under spinal.
But don't try that at home. When the audience came in, many of you may have heard the music that was playing. It was the Beethoven cello and piano sonatas. And we debated about Beethoven or Bach to be the music. And I was intrigued by your volunteering to have an fMRI of your brain while you listened to Beethoven versus Bach. And the difference in reactions. Maybe you want to talk a little bit about that?
Yeah, well, we both share and we both play Bach, you on the cello and I on the piano. But and for Bach lovers, there's been the most incredible 11 days, of course, on WQXR. But I particularly love the B minor Mass, and there's a particular part which fills me with rapture and terror and all sorts of peak feelings, whereas the analogous passage in the Beethoven Missa Solemnis doesn't move me. And anyhow, I had an fMRI done when they played the Bach, and I lit up everywhere. And not merely in the auditory areas, but in emotional areas and memory and cognitive, cerebellum, everywhere. And with the Beethoven, I didn't. I think I did a wrong to Beethoven, and
I won't tell him.
And I'm now becoming rather fond of all sorts of Beethoven things.
The question is, how much of this is intrinsic? When you were 5 or 6 years old, when asked your two favorite things, I believe you said Bach and smoked salmon, although maybe not in that order.
No, I said smoked salmon and Bach.
And Bach.
Yeah, right. And
little has changed, apparently.
No, they're still my favorite things. Well, my father was a good pianist, and I had 3 older brothers, and their music teacher when I was growing up was always giving them Bach, and I would hear him shouting and banging the piano and saying, no, 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 but I sort of grew up partly on Bach. But things are gradually spreading now, and I've even been enjoying some Debussy.
But the response to music appears to be innate, that even infants, before they've been steeped in Bach, have a reaction.
Yes. Well, certainly 2 friends of mine, parents who are both good musicians, are positive that their children responded in utero, and in the first year of life were fond of, had been imprinted, at least with certain rhythms, not necessarily certain melodies. The synchronized response to rhythm, whether it's keeping time or to real or imagined music, seems to develop very early and to be innate to human beings, although it's not in chimpanzees or other primates, and it's not in dogs. Once when this came up, and I said it's not in dogs, there was someone in the audience who said, now I realize why I've spent 5 years trying to teach my dog how to dance and getting nowhere. Although there may be there may be a real musicality in some birds, but musical, like mathematical ability, tends to show itself very precociously, perhaps partly because it's not dependent on too much experience outside it. But I think one can also become musical later. And there was a very striking article by a man called Mithen, a psychologist. Actually, he calls himself a psychoarchaeologist in England. And he said when he was at school, he was told that he had no voice, that he had no ear, that he shouldn't sing, that he wasn't musical, and should avoid the entire subject. And he did this until he was in his 40s. And he then designed an experiment. He decided to have a year of singing lessons with functional brain imaging at the beginning and at the end. And to everyone's surprise, and especially his own, he rather enjoyed the lessons, and he did rather well. And by the end of the year, he joined a choir. And there's the most extraordinary change in the before and after MRIs. And so it's never too late.
Well, I was intrigued in Musicophilia, the chapter you wrote about looking at the brains on autopsy of geniuses of various stripes, and how the brain of a physicist is fairly indistinguishable from that of an economist, but that performing musicians had very distinct looking brains.
Well, I think if we could look delicately enough, we might find a difference between a physicist and an economist. But the brain responds very readily and almost grossly to musical experience, and especially playing instruments. Just listening, the so-called Mozart effect, doesn't work really.
Well, what's the difference?
Well, you don't engage your brain properly at various levels, really, I think, unless you play or imagine you're playing. But certainly various parts of the brain, as this thing with Mithen showed, you can get changes, and I think a year of Suzuki violin will certainly change a brain. Whether you have to continue it, I'm not sure.
Well, should music be part of standard medical treatments, the listening or the playing?
Oh, well, yeah, I think for many reasons. I first saw this with my awakenings patients and people who were frozen and speechless and could not initiate any action. But I was told that they could dance and sing in response. And they do so, and it is amazing. A while back, I showed the documentary of awakenings here at NYU, and you saw one person who was very frozen and would sort of spend hours curled over like this with a finger on one of her spectacle lenses. But when she was taken to a piano, she loosened up, and she loved Schubert and Chopin and played beautifully and wasn't Parkinsonian while she played, and almost as soon as she stopped. So there's a remarkable sort of on-off response to music, and now one can have little iPods. I think people with Parkinson's can, who would get badly stuck otherwise, can. Now, of course, they may not be able to initiate turning on the iPod, but there will have to be something automatic. But in other ways, when I see patients who are aphasic and who have lost the powers of expressive language, I may suddenly sing something to them, happy birthday, whether or not it is their birthday and whether or not it is appropriate for a neurologist to sing happy birthday. And often I encourage them to join in. Actually, with all my elderly patients, they all know a bicycle made for two. So they will join in there. And in joining in, they will not only get the melody, but perhaps some of the words. And this will astonish them, because it will show that words are still available to them, even if only embedded in the music. but one may then be able to disembed this and, in fact, create capacities for language in the right hemisphere of the brain, which is usually almost silent as regards language. And even if there's been a lot of damage to the left hemisphere, so music can be a sort of bridge to language. And I think music is also can be wonderful for people with dementia or amnesia who are no longer able perhaps to access their own memories, who've lost their autobiography, but familiar tunes will be recognized and will bring back the time when they heard it and all the associations and animate them in the most extraordinary ways. So I think music therapy needs to be available in hospitals and not only for patients like this, but all sorts of patients. I mean, it was found in the First World War with wounded soldiers back from the front. Volunteer musicians would come in and pulse and blood pressure would get more normal and other physiological things would improve. I think we need music.
Do you think there's any intrinsic connection between music and doctors? I mean, there's a doctor's orchestra here in New York City, and there's one in Boston, and one in Houston, and one in California, and two in Europe, one in Israel, one in Australia, but there's only one lawyer's orchestra, and there aren't any accountants' orchestras.
Yeah,
there are no Wall Street orchestras that I know of.
No, I went to a wonderful Mozart Requiem with a physician's orchestra. Well, certainly, I learned early, both my parents were physicians, but we would have chamber music at home, and certainly my father and many of his colleagues were musical physicians. Whether this just happened, I know some physicians who are rather unmusical. And also, as I think I wrote to you, we started corresponding right back in '03. I had received a letter from a lawyer in Australia. He'd written a biography of Tchaikovsky, who was a lawyer before he turned to music. And this lawyer was himself very musical and thought there was a strange correlation between music and the law. So, who knows? I mean, what's always being discussed as to what extent music and mathematics go together. Yeah.
I believe it's 7 o'clock, and we have to keep on schedule for these schedules.
We only just started.
Well, I want to thank you so much for joining us, and for the audience for being attentive listeners, and perhaps we'll just stay for another few hours after everyone else leaves. Thank you all.
Thank you very much. Thank you all.